Well, hello everyone, and welcome to today's Heart Talks webinar. I'm Celina Gorre, and I'm the CEO of WomenHeart, and I'm really happy that you are all able to join us today for this really important conversation. At WomenHeart, we're dedicated to providing education, support, and advocacy for women living with and at risk of heart disease. And for those of you who may be new to us, we are the leading patient organization focused exclusively on women's heart health. And we work to ensure that every woman has access to the information, care, and community she needs to thrive. So before we dive in, I wanted to take this quick moment to thank our sponsors, the Boehringer Ingelheim and Lilly Alliance, and Roche Diagnostics for their generous support for today's webinar. Their partnerships make this important conversation and many other important conversations possible. This year, we're really putting a special spotlight on cardiorenal metabolic health, also known as CRM health, because we know that the heart and heart health doesn't happen in isolation. Many women with heart disease are also managing other conditions like kidney disease, diabetes, obesity, and other metabolic disorders. Just last month, we also hosted a heart talk focused on how nutrition and lifestyle strategies can support CRM health. And if you missed it, I would really encourage you to check out the recording and our Heart Talks, our archive found on our website or our YouTube channel, WomenHeart TV. And stay tuned because we've got many more exciting topics that we are going to be sharing along with resources throughout the year to help women better understand and manage these interconnected conditions. So today's discussion will continue that focus. We're going to explore the intricate connections between the heart, kidneys, and our metabolic system. These conditions don't just overlap by coincidence. They actually impact and worsen one another and are extremely interconnected. Understanding these connections is critical for prevention, early intervention, early detection, and better long-term health outcomes. I'm really thrilled to have Dr. Kohli to provide this expert perspective. And we're also joined by our WomenHeart champion, Danielle, who will be sharing her personal journey later in the conversation. Her story really brings this topic to life, and it highlights why it's so important for women navigating these interconnected conditions to share their stories. So let's start by introducing Dr. Kohli. Dr. Payal Kohli is an internationally recognized expert in cardiovascular health. She's an associate adjunct professor at both Johns Hopkins University and Duke University, and the founder and medical director of Cherry Creek Heart in Denver, Colorado. Dr. Kohli specializes in general and preventive cardiology and in cardiometabolic disease. She's also a medical correspondent and a podcast host who works to make complex medical topics understandable for patients and colleagues. So, Dr. Kohli, welcome. Let's get right into it and start with the basics. Can you please explain what cardiorenal metabolic health is and why it's something that we should be paying attention to? We also know that there are lots of different ways to this syndrome is termed, but why don't we kick it off by have you explaining that to us?
Thank you so much, Celina, and thank you all for coming today. What a pleasure to be here to have this important conversation about heart disease, and not just heart disease, but cardiovascular, kidney, metabolic disease in women. And as we know, think of all the women in your life. This is the most likely thing that's going to happen to any of us or any of the women that we love. So I think it's so important to sit down and learn a little bit more about it. And I think today in 2025, we've gotten smarter about how we think about heart disease. Heart disease has outsmarted us for so many decades. And finally, as the medical community, we've realized it's not just the heart in isolation, but as you said, Celina, the combination of the heart, the kidneys, and our metabolic system, which really means our weight, our insulin resistance, our pancreas, how we carry our weight on the body, and how the blood vessels actually interconnect all of those organs. So that's the link between all these organs. The cardiovascular, the kidney, and the metabolic system is the blood vessels. And inflammation in the blood vessels is what causes the conditions to coexist often together. And I'm sure we'll hear from Danielle later as well. So I want to talk about the CKM syndrome, cardiovascular kidney metabolic syndrome, because I want every single one of us on this call to go home and stage yourself for this syndrome.
Mhm.
So this is a new syndrome that the American Heart Association introduced about a year ago. And what it is really to help kind of blur the lines between, okay, just go see the cardiologist, just go see the kidney doctor, see the endocrinologist, because all these organs are working together. So essentially it's staged like we stage cancer. Stage 0 being perfect and stage 5 being advanced. Now, if I asked you to guess what percentage of America was stage 0, Celina, what would you guess?
Oh, that's not fair. I probably would say 20%.
10%. So
Wow.
90% of us have
Wow.
stage 1 or higher CKM. Now, if I said 90% of us had stage 1 cancer, the news outlets, the media outlets, everybody would be talking about it,
Yeah.
would be all over, we would be paying attention. And yet we're all headed for heart disease, the most likely thing to happen to us, and we're being ambivalent. So I think it's a really nice way to get a grasp on what you need to change. And the nice thing about this is you can go back to stage 0. And so if you are in that stage 1 or loved one is that stage 1, you can actually do something to make it go back to 0.
Yeah, wonderful, wonderful. Many women in our audience are familiar with key health numbers like cholesterol, blood pressure, glucose, and weight. So some of the various facets of this syndrome. How do these numbers give us some insights, perhaps, into what you're talking about, which is cardiorenal metabolic staging, if you will, and what should women specifically be looking for?
So these are really important numbers, and I would add a few more to that list there. So blood pressure
Okay.
less than 120/80. People often think the 120 to 130 is normal. That's in fact, considered pre-hypertension. You're about to head
Yeah.
for high blood pressure. So definitely want to stay below 120 for the top number, below 80 for the bottom. Your blood sugar, your hemoglobin A1C, which is a 3-month reflection of your average blood sugar. It's a blood test, should be well below 5.6%. Many of us get pre-diabetic as we get older because our pancreas, that's the organ that makes insulin, starts to get a little lazy. So that's a natural history of what happens. It's up to us to reverse that process by being more active, watching the carbs, making sure we're eating the right things, sleeping enough, managing our stress in order to keep that pre-diabetes in check. Cholesterol, the bad cholesterol, the LDL, for most people who don't have heart disease should be less than 100. But for some people who don't have heart disease but have a family history or other things, should be less than 70. So that LDL number is really important to know. I'm going to add a few more on there. We talked about weight. We've normally looked at a metric called BMI, or body mass index, which is your weight over your height squared in meters. But that's too antiquated. We actually need to look at something called waist circumference, which is how much
Mhm.
weight are you carrying on your belly, as well as something called waist hip ratio, as well as something called waist height ratio. So how much weight you're carrying on your tummy based on your height and your hip circumference. Because as we all know, women come in different shapes and sizes. Some of
Yeah.
it is genetic. So it's not necessarily the same criteria for everyone. It's really how their body proportions are that help us decide. We also need to look at something called lean body mass. So that's those scales at the gym that tell you how much fat mass you have versus how much muscle mass you have. And we know that as women, our muscles start to actually get, atrophied by the age of 30. So 30 is when we start to lose muscle mass. Menopause accelerates that process. So it's really important for us to keep track of that number. I would throw in 2 other numbers for you to know. One is called a lipoprotein A. This is a
Mhm.
genetic marker of risk that's elevated 20% of us. And it's a simple blood test. And if it's high in you, we need to have your kids checked. We need to have your parents, your siblings, all of your family members. So you need to get that test done, not just for yourself, but for everyone else. And finally, a urine test, because remember, we talked about CKM syndrome. Kidneys are part of this. It's called a urine microalbumin to creatinine ratio, or UACR is the abbreviation. Ask your doctor for these tests, because oftentimes, especially the lipoprotein and the UACR, we're not doing on a routine basis.
Yeah.
The UACR tells us if the kidneys are leaking protein into the urine long before they ever start to misbehave.
Um, I just want to remind everyone who might be taking notes rapidly here that this will be recorded, so you can go back and listen to what Dr. Kohli is recommending you to ask from your clinicians. So I wanted to also ask another question because you mentioned, Dr. Kohli, pre-diabetes, and that's sort of the stage where your doctor's going to say actively, watch your diet, exercise more. What if somebody has been pre-diabetic for 5 years? How do you kind of think about that person in your clinical practice?
Yeah, so prediabetes is a little warning from our body that the
Yeah,
pancreas, the organ that makes insulin, is not able to keep up. And as I said, it can happen for age-related reasons that you get pre-diabetic. Certainly, weight makes you pre-diabetic. So if you have excess weight on you, the body's not able to kind of keep up. Losing weight can help to reverse that pre-diabetes. Menopause can accelerate the onset of pre-diabetes. A lot of women, for them, the first stress test that their body ever had was how they carried their pregnancy. So if you've
right.
been pregnant before, I want you to think back to when you were pregnant and ask yourself if you had gestational diabetes, which is kind of the sort of equivalent of prediabetes during pregnancy. It's a warning from your body that it can't keep up. If you had gestational hypertension, which is high blood pressure during pregnancy, the blood vessels not being happy when they're under stress, or if you had preeclampsia, which is an extreme form of that, or if you had a premature baby or a low birth weight baby, these are all signs that you are going to go on to get cardiovascular metabolic disease. So you're at high risk. So if you're someone who's been struggling with prediabetes for a long time, you want to think about how pre-diabetic you are, because the natural history of prediabetes is that it progresses to diabetes. Now, the rate
Right.
of progression is different for each one of us as women. It depends on lots of external factors. So some people progress pretty quickly. Some can take many years. Even infections like COVID, we're realizing can cause prediabetes or diabetes after an infection because of the inflammation from that particular infection. So lots of factors go into it. But I would say if you've been pre-diabetic for a long time and you're just barely pre-diabetic, one strong thing you can do is slap on something called a continuous glucose monitor. I put this on my mom, actually, because she's exactly this woman. She's been
Yeah,
pre-diabetic for many years. We're South
yeah,
Asian, so we have a
yeah.
genetic tendency towards pre-diabetes too. And
Mm,
a little sticker on your arm, and you wear it for 2 to 4 weeks. And you get the app on your phone that tells you exactly what your sugar is running all day long and exactly how your body responds to food. So you can alter your behavior. So for her, for example, certain foods like mashed potatoes made that sugar spike. What I told her to do is to take a little walk after every meal, because that makes the muscles take up the sugar so that it's not swimming around in your bloodstream, actually causing trouble with the blood vessels, but actually goes into the muscles because you're taking a walk. And that's brought her numbers down nicely. So certainly lifestyle behavioral changes. This is an over-the-counter thing. You don't need a prescription for a continuous glucose monitor. You can order it online yourself from many different vendors. That's a nice way to use diet and lifestyle behavioral changes to alter it. If you're high on the pre-diabetes spectrum, and I would suggest you check something called a calcium score, which is an X-ray of the heart. Over the age of 40, it tells us if you already have plaque. If you're pre-diabetic over 6.0%, 6% or higher, and you have coronary calcium, then I actually start to think about even using medications, because it's all a
mm.
spectrum of risk. And if you've already put down plaque, the last thing you want to do is leave yourself pre-diabetic, which we know is a risk factor. So your body puts down more plaque.
Yeah. Sort of to continue on with that line of thinking, you mentioned inflammation as sort of the connector across heart disease, kidney disease, and metabolic disorders like diabetes. So can you, and I feel like inflammation, certainly in the conversations we've had in within the Women Heart community, is a recent sort of, recently on the scene, right, in terms of talking about how these things are all interconnected. So we've learned how to address diabetes, we've learned how to address, heart disease, et cetera. But how do you recommend us addressing inflammation in kind of everyday life?
Yeah, I mean, inflammation comes from obesity, it comes from stress, it comes from lack of sleep, it comes more often in women. So women tend to have more inflammation, more autoimmune diseases, their immune system's more ramped up than others. And again, menopause can also change how our inflammatory profile looks. So I would say a couple of things. If you're overweight, you certainly need to work on losing the weight, because that's a key common pathway for inflammation. And inflammation, excess blood sugar, all of these things make the walls of the blood vessels sticky so that your cholesterol gets stuck. That causes more inflammation, and then more cholesterol gets stuck, and that's how you end up developing these blockages. That inflammation also affects the kidney function, which then further affects your blood pressure, your stickiness tightness of your blood vessels, what have you, through chemicals. And it's just a feed forward process. So the first thing I would say is evaluating risk factors for inflammation, autoimmune conditions like lupus, rheumatoid arthritis, HIV, anything like that, the chronic inflammatory conditions that can raise your inflammation. If you have those, I say you have a target sign on you for inflammation. Obesity is a huge one, so if that's a reversible one. Checking a blood test called a high sensitivity CRP, which we use as a marker of inflammation. So if that test is amped up, that volume on that inflammation is turned up, I'm more aggressive with your other risk factors like your cholesterol and your diabetes and your blood pressure, more likely to start a medicine for those types of risk factors earlier or drive the numbers down lower to kind of counteract that chronic inflammation that you have. Certainly medications like statins, which are cholesterol medicines, can help reduce inflammation. We know that those drive down that CRP number. But I think figuring out the risk factors and then assessing whether you are someone who has what we call hyperinflammatory type of heart disease, that target sign on you is a little bigger for inflammation than for some other woman. And if that's the case, then you need to be even more aggressive proactively, because it's not just, like I said, heart disease, it's kidney disease, metabolic disease, cancer, all types of other conditions that you would be higher risk for.
Dr. Cole, you also mentioned Lp(a) a little bit earlier as a genetic marker for risk. And we know that currently there are no medications available to directly treat Lp(a). But would you think about if you got the test and you discover that you are high for Lp(a), would you recommend treating similarly similar to inflammation? Would you recommend treating the other symptoms more aggressively or other risk factors more aggressively if you, in fact, do have that genetic marker?
Absolutely. That's what we do today. We treat you more aggressively with the other risk factors. We think about starting an aspirin in you if you're over the age of 55, because we know that Lp(a) doesn't just cause cholesterol, it causes blood clots as well. We think about screening your family members, as I said, and we really look for heart disease more aggressively, not just treat the risk factors, but we would be more likely to do not just a calcium score, which is a quick X-ray, but a full CT scan, looking for something called soft plaque that hasn't quite hardened or calcified yet, so might not show up on a calcium score. So I'm doing a whole lot of things with women who have elevated Lp(a). In fact, if it's young women who are about to go on to get pregnant or carry a pregnancy, I talk to their OB, because we know that pregnancy can raise your Lp(a) a little bit. So for those women, I'm more likely to start them on a baby aspirin before they get pregnant, because it makes their pregnancy more likely to be successful, less likely to have complications. So getting it checked so that, again, this empowerment that comes from knowing our numbers, knowing our risk, and really modifying what we do so that we're smarter than the disease. Because if we just leave things alone the way that they are, Celina, we're going to go on to get heart disease. That's the most likely thing that's going to happen to any of us. So now that we know that 80% of heart attacks and strokes are preventable with risk factor management, we have the recipe. It really behooves us to step up, know our numbers and know our risk, and be our own personal health advocates.
It makes me think about that you describe a woman, let's say in her 30s, who doesn't have any risk factors in terms of, her lifestyle, but just learned that a number of people in her family died of heart attacks relatively early in their life. How would you recommend that person sort of taking proactive steps to make sure that, in fact, they don't progress on to getting heart disease?
I'm so glad you brought that up. There's a great study that just came out that looks at our risk for developing dementia when we're 60, 70, 80 years old. And it actually depends on what we do in our 30s, 40s, and 50s, what we're eating, how we're sleeping, how we're exercising. So I think it's such a critical point for women who are young women, even to start to think about managing their risks so that we age better. Because we often talk about lifespan, right? Living longer.
Yes.
But we don't just want to live longer, we want to live better. So for a young woman who has a target sign on her because she's had a family history, I would check an Lp(a) for sure, because we want to make sure that's one of the biggest drivers of kind of genetic family risk. Even if that comes out negative, there are lots of unidentified factors in family history that we don't yet know. We know she has that target sign on her. I would be very, cognizant about her blood sugar, her weight, her waist-hip ratio, her urine microalbumin to creatinine ratio, all the other metrics that I measured, as well as her CRP, to try to make sure that I've really optimized her on all parameters. And as you know, we change over the course of our life as women, especially with that
Absolutely.
inflection point of perimenopause and menopause, where the risk sort of asymptotically goes up for us as women. So I call that like the biggest transition in our life, because we're different from men in the sense that we have to carry a pregnancy. So we have this reproductive life cycle. We start our periods, then we have our reproductive years, and then that suddenly ends. So you can imagine what that does to our body, our blood vessels, and our organs when there's such a different hormonal environment than before. So for women, we really need to make sure we take those, when we're in our prime of our life, seriously in terms of risk factors and prevention, optimize everything, but then keep checking along the course of our life, especially around menopause, after menopause, because that's when the risk goes up so much that we have to try even harder to try to balance it out.
Dr. Kohli, I have so many more. I mean, every time you respond, I'm thinking there's so many more questions to ask you. But I do want to bring Danielle in. But before we do that, I just want to pose this question to you around the folks who might be hesitant to use medication to address some of these risk factors more aggressively, right? I think those folks may be afraid that they have to be on a drug for life, right? So how would help us reframe that so that we see that as part of the suite of tools we might have in our toolbox to ensure that the diseases that or the syndrome or aspects of the syndrome don't progress into more serious levels of disease.
It's such an interesting way to think about it. I like to use the analogy of an old car that we love, right? Yeah, and in
Yeah.
order to keep it running well, many years after you bought it, you have to get it regular maintenance. You might have to do more things to it than you did before, but you certainly don't want to give up on it and just keep driving it until it sort of stops driving one day. I think that's how we need to think about aging. We need to take control of aging well. And that means really embracing the therapies, the interventions, the diagnostic tools, and the treatment tools that we have so that we can make sure that our organs don't just do what they're going to do if we leave them just be, which is to start to decay. So using medications to really balance out our risk to help us age better so that we can live longer. And I like to ask people, Celina, what are the two things that you're most afraid of as you age? And I would say most of us will say having a bad stroke or having dementia and losing
Mhm.
ourselves. And by
Mhm.
keeping your bad cholesterol below 70 or LDL below 70 for most of your adult life, I can substantially reduce your risk of
Mhm.
either of those. So I think thinking of medicines as a way to help us live better, not
Yeah.
as, oh my gosh, I'm doing something bad to myself. And this is, even comes true with the obesity medicines. For the longest time, we told people get off the couch and exercise and do better. And now we realized it was our fault. We weren't recognizing that these people's thermostat was just set higher, and you need to interrupt that kind of disease process inside of them. It's not their fault that they have extra weight. It's our fault that we didn't come up with the right medication to help them lose the weight. So I like to think of the medicines as a way to empower you to feel better, age better, rather than saying, oh, it's a crutch or something that I'm worried I'm going to be on. I know for myself, the minute I turned 40, I started myself on a statin because I definitely don't want to have dementia or stroke. And I know that my family tends to run a high cholesterol because that's my genetic set point. 75% of our cholesterol is genetically determined. Only 25% comes from diet. So it wasn't something I was doing. It was just the way that I was made. So I really think embracing that culture of trying to really live better is how we're going to start to think about using medicines to make us do that.
Absolutely. I love that. I love that. So I want to bring Danielle Poole into the conversation. Danielle is a Women Heart champion from the class of 2023. I mean, like brand
Wow.
new. And she's joining us all the way from North Carolina.
Yeah.
Danielle has firsthand experience managing some of these conditions that we've been spending some time talking about and can share how she's navigated this health journey of hers. So Danielle, thank you so much for being here today. And I'll just start with asking you if you can share a bit of your journey. What led to your heart disease diagnosis and what other health conditions have you had to manage along the way?
Thank you for having me. Can you hear me okay?
Yes.
Okay. So I had a heart attack in October of 2022. I had sudden onset symptoms. So my diagnosis was immediate. what I came to realize after the diagnosis and cardiac rehab and treatment is that I probably could have avoided that if I had had more information, like what Dr. Kohli is talking about. So, my other health conditions are that I had fault diabetes and hypertension most of my adult life. I had my first pregnancy at 19. I had gestational diabetes. I had another pregnancy at 30, and I had gestational diabetes again. Um, at 34, I developed prediabetes and was full diabetic within a year or so after that. I went on medication, but I had the attitude of, I don't want to be on these medicines for the rest of my life.
Yeah.
So I tried to control with diet and exercise. And I also had gastric surgery, a gastric bypass. And once I had gastric bypass, my everything went into remission. So normal A1C, normal cholesterol, and normal blood pressure. So I was very happy and satisfied with my results, and I was more active, had more energy, definitely a more active lifestyle afterwards. And I actually had done a hot yoga class the morning before my heart attack.
Um,
So, my heart attack was about a year after my gastric bypass. And
um,
so I had to go on another cocktail of medications. And that is when I came to that acceptance point of if I have to live my life with prescriptions, I can do it, be healthy, still have a more active lifestyle, and keep going. So that's most of my health journey. Recently, I celebrated losing a total of 100 pounds. I,
Amazing.
yeah, like literally just last week, I was so excited about it because it's been like 4 years total. But yeah, about 4 years. So but along with the weight loss, I again have a normal A1C, a normal blood pressure, a normal cholesterol, no signs of cancer. So I'm really proud of my total health right now, but yeah, that's been my journey.
Amazing. Going back to your pregnancies, Danielle, you mentioned that both times you had gestational diabetes. Was there a discussion during that time that this increased your risk of type 2 diabetes or heart disease sort of in the future?
Yes, so there was discussion of type 2 diabetes. So not so much because I was pretty young with my first pregnancy. So at 19, my doctor did not mention that to me. But at 30, when I had my second child and I had gestational diabetes, and my primary care actually did my prenatal care as well. So she was well aware of my total health. She did discuss that that meant I was more likely to develop diabetes or prediabetes and diabetes, and to consider those things in the diet and exercise. There was never a discussion of cardiovascular. And as I understand it, that's a more recent connection for the general public like myself, but I never made the connection. It was, I mean, I've learned all of that since my diagnosis and since being exposed to Women Heart.
Yeah. So you've also, like you mentioned, been working closely with your family doctor, and that relationship is really, really important to you, and
Mhm.
that there's a lot of trust built into that relationship. How does that relationship support your journey, and what does I imagine that part of what you do with your doctor is sort of the shared decision-making model of really working together to get the amazing results that you've gotten. So how would you kind of advise somebody who is looking for that partner in their doctor to make good decisions about their life, sort of and their health?
It's a relationship. It really is. It just has to be a comfortable relationship, just like any other relationship that you have. Um, my primary care was, well, she retired, but she was my primary care for 22 years.
Wow.
And she really walked me through the process, especially with that second pregnancy where I had the gestational diabetes and my starting weight at the beginning of pregnancy was drastically different from what it had been at the. She really did make me aware that it was at that point that this we really need to start working on diet, nutrition, exercise. I explored the gastric bypass surgery, and she didn't support it. She didn't think that it was necessary for me. She thought that I could do more on my own, like with nutrition
Yeah.
and diet. And I went ahead with it, right? And I told her, I was like, I said, I really want to do this because I feel like I need this almost like the jump start, right?
Mhm.
I knew
Mhm.
inside me there was a very active person, but it's
Mhm.
very discouraging to every time you start exercising to sweat profusely and be short of breath and just feel like what your mind or what you believe you can do, your body's just not capable of. And so once I started the process, she got on board with me and she was like, I'm always going to be happy for any good outcome that you get. She got
Yeah.
on board with it, but when I initially asked her, she was like, I don't think that's for you. And I just, so we had a wonderful relationship. I miss her dearly.
Yeah.
But some of it is just research as time goes on, things develop and are revealed. And then some of it is like what your doctor is comfortable with, like how far they're willing to push you and how comfortable they are with you. So I value that relationship that I had with her, but I also see the parts where things could have went differently.
Yeah,
Yeah.
well, I want to commend you for bringing
Yeah.
it up because oftentimes, some physicians wait for the patient to say something, whether it's about weight or so always feel empowered to bring up
Mhm.
options with your doctor, ask them questions, talk to them about it because it may open the door for that conversation, especially when
Mhm.
it comes around weight, everybody sort of manages it differently.
Yeah, absolutely.
Mhm.
And Danielle, if somebody was just starting this journey, they've just been diagnosed with, whether it's heart disease or kidney disease, how would you advise them in that journey? Maybe they're afraid, maybe they're, are really hesitant to take medications. What's the like how like what would you say to them?
Information and support. So
Yeah.
both of those things empower you. So get as much information as you can, credible information. Of course, you don't want to just grab the internet and read anything, but try to get as much credible information about your conditions as possible. And then look for support, whether it be from your own village or other resources like support groups or things that your doctor may recommend for you. But get support that has a shared experience so
Yeah.
that when you're considering the possibilities, you're not stuck with only your own thought process. You have to be open to it. And of course, you're going to listen to your own voice the most or let your own voice be the loudest, but you want to be open to other resources, other possibilities, other people's shared experiences, information and support. Those are the two key things, and you have to be proactive. Don't pretend it doesn't happen. And that was one of the things that my doctor really pulled out of me because between the whole decade of 20s, I was gaining weight every year. Like small pounds every year, and instead of approaching it from how am I going to live my life? How am I going to approach my diet and exercise? What type of active person do I want to be? I always kind of was like, I'll do a diet and lose 10 pounds before I go to the doctor. So she doesn't know that I've really gained 20 pounds this year. So she was really influential about, saying, no, let's just deal with it as a holistic approach. Like what type of active life will you lead? So
Yeah,
yeah.
yeah. Thank you. We are going to open it up to questions in a second, but I wanted to go back to Dr. Kohli because one of the experiences that is very common in the Women Heart community is the experience of not how do I put this? Sort of struggling to get their doctors to take them seriously, sometimes not being believed or having their symptoms minimized. And we often talk about how women's symptoms of heart disease don't fit the conventional mold and sort of these stereotypes of heart disease being a man's disease, et cetera. So what advice would you give for women in terms of advocating for themselves in the context of our healthcare system?
Such an important discussion because you're so right. And sometimes it's not even about symptoms. It's about like what Danielle was saying, just, ways to manage what you have or treatments or prevention or what have you. So I would say the first thing I would say is that you know your body best, right? You are your own best advocate. And so the way that I sort of view the role of the doctor and the patient, it's not a top down. It's their role is to be there to help you understand how to best live your life and manage your symptoms. Mm-hmm. So if you don't have a relationship with a doctor who is doing that, who's A, listening, and B, taking in what you're saying, understanding and reflecting back to you with good information and options, then I do think it's important to find a doctor that can listen to you in that way. And sometimes it takes some time because it is hard. It's almost like a romantic relationship. Two people may not necessarily fit. There's a spectrum of personalities out there. So, you have to trust your doctor. You have to make sure they listen, they reflect back to you with knowledge and information. And you have to make sure that you're doing your homework, just like Danielle did, coming to the visit prepared. So I often tell people when you go to a physical, you don't just show up and have your physical. You have a checklist of questions, of tests, of things you've done your research, and you come in there informed. And for me as a physician, I love when that happens because now I know where your head is. And I know, what you're thinking and how to take you where you want to be. Whereas otherwise, most of the visit is spent me trying to figure out where it is that you want to go, how aggressive you want to be, and what have you. So I think feel free to bring to the table your cultural, religious, spiritual, and personal preferences so that the doctor can really make a personalized treatment and prevention plan for you. Don't be afraid to speak up because your doctor wants to hear from you. And the doctor wants to be challenged. The doctor wants to know, okay, why are you recommending a cholesterol medicine, Dr. Kohli? I'm only 40 years old. And then I can sort of give you the information and you can make the most informed decision. So I always tell my patients, you're the captain of the ship. I'm just a crew member, but my job is to feed information to you as the captain, and then you help to make the decisions and tell me where you want to take your ship.
I love that analogy so much. I think we could all gain some confidence in believing that we are the captain of our own ship. So let's go to questions. We've got one from Robin. Her first question, or the first question is, do you recommend a certain monitor? I think this is a CGM. I think that's what she's referring to here, to take those readings.
So if you're a diabetic, Robin, then the insurance will cover the monitor. So you don't even have to pay for it out of pocket. You just talk to your doctor and they'll apply and your insurance will take care of it. If you're a pre-diabetic, then there are a number of different companies. One that I like is called Stelo, Stelo. There's another one called Abbott, Abbott. And there's one called Dexcom, Dexcom. And they're about $89 to $99 for a month. I usually recommend only a month at a time because that's really all you need to kind of understand your body and your behaviors. So you'll put the sensor on for 2 weeks on one arm, rip it off, put it on another 2 weeks, the other arm. And again, real-time information on the app. And my mom always jokes with me that I'm the reason that she's pre-diabetic because she and I got into an argument one day and her sugar went way up because the stress response got activated and it was fight or flight and the cortisol. And so she blames me for her pre-diabetes. So it's a really nice way to get attuned to your body. And if you do try it, encourage other people in your family to try it as well.
Absolutely. And I've heard, you talked about living well for longer. I know that is sort of in the longevity realm, the CGM is a magic tool almost, right?
And you know what I like to say, Celina, is that like our genes are our hardware of our computer, but the way we live our life is the software. It changes how our genes are expressed. That's a phenomenon called epigenetics. So what we do in our life changes how our genes are actually turned on. So don't feel like, okay, I have family history, I'm doomed. Feel empowered that you can age better, live better, and really change how your genes behave, essentially.
Fantastic analogy because you can upgrade that software on a regular basis, right? That means it doesn't have to stay the same and you don't have to it gets slow. That software gets super slow if you change it every now and then. So that's really important. I've got here another question about logging what you're doing during the day and when things spike and drop. Um, Again, I think this goes back to the CGM. Would it be helpful to the doctor if you brought those results in to show what the CGM readings were, how that reflect your diet reflected in the CGM
Very
readings?
much so. And I would say even for yourself, more so than even the doctor, what you're eating, it's called the glycemic index, which foods trigger what. So often my pre-diabetic patients ask me, can I eat like fruits because they have sugar in them? Well, fruit sugar responds differently in your body than a cookie or a brownie. And so it's about refined carbs versus, unrefined carbs, complex carbohydrates. So I would say for sure be logging that. There are also many other monitoring devices that certain women, people like to try that may help you. The Aura Ring, the Apple Watch, which has an EKG function on it, we can monitor your heart rate, see if you have anything called atrial fibrillation or AFib. So lots of new trendy things. Depends a little bit on what type of person you are. Do you react
Yeah.
better to information? I have a patient who has hypertension, high blood pressure, and every time she checks her blood pressure, it goes even higher. So that's somebody who I say, don't monitor. I'll monitor. You don't worry about it. But on the other hand, there's some people who say, okay, now I know exactly what I should eat, what I shouldn't
Yeah.
eat. I was eating oatmeal every morning and it's raising my sugar. Now I'm going to stop
Yeah.
that. So kind of assess how you are and then decide where to put your kind of sweet spot for monitoring devices.
Yeah. And no pun intended, right, Dr. Kohli? Not the sweet spot necessarily.
A little pun intended.
Uh,
Yeah.
but the other thing I would just add to that is not every food not everyone reacts the same to the same foods, right? So I think that's the whole point of sort of getting your assessment of the individual reaction. We've got another question about car carvedilol
Uh-huh.
and statins and blood pressure medications and how they impact the kidney. Do these sort of add, challenges to managing your kidney and metabolic health?
So kidneys, if you think about it, guys, they filter our entire blood, right? So it's a huge network of tiny little blood vessels that go through our kidney. So if you have cholesterol deposits in them, they're clogging up your blood vessels. Think about it like your shower, or the pressure by which they're feeding those filters, and the filters are like as thin as tissue paper. So you're putting a high blood pressure into those kidneys, you're popping those filters open. So statins really help to reduce the cholesterol deposits in the blood vessels of the kidneys all over the body, in fact, including our brain, our heart, everywhere else. And the blood pressure medicine really rests the kidney because it decreases, it's like a garden hose pointed at a sheet of tissue paper. You're going to pop it open. Whereas if you turn down the volume on the garden hose, it's much more likely to be able to do its job. So I like to say these medicines rest our organs. They rest the heart. The heart has to do less work when your blood pressure is lower. The kidneys have to do less work. And then the blood vessels get less pressure on them like a water balloon. So you have less stickiness in the walls of the blood vessel. That makes it less likely to put more cholesterol, create more inflammation, cause more problems. The natural history of what happens to our blood vessels as we age, our skin gets wrinkles, our blood vessels get stiffer, our heart gets stiffer. So it really means that we have to try harder not to develop hypertension or high blood pressure because the arteries are going to get less elastic. They're going to get tighter as you get older and more stiff. So it really behooves you to watch the sodium in your diet. And so for someone like Danielle, who already has high blood pressure, I would put her on a 1,500 milligrams or less in 24 hours diet. And, burrito bowl from Chipotle actually has more sodium than that. And so sometimes I even tell people to count their sodium proactively because 90% of America consumes too much sodium. And so the chances are you're probably in that box, especially if you go out to eat a lot or you order in or what have you. There's a lot of sodium in everything from drinks and pastas and breads and sauces and everything that we eat. So watching the sodium, because we know that our blood vessels get stiffer as we get older, is really important too.
Thank you so much for that. We have to wrap up, but I want to ask each of you to think about your parting message. What's one takeaway you want to make sure everyone on this webinar takes with them? I'll start with Dr. Kohli.
I would say that, your health is in your control. We can't be passive passengers in the journey of our health. We have to be active. And that includes everything, knowing your numbers, knowing your risk, advocating for your health, and being proactive to really change your health outcomes. And you make a small change today, ladies, your train is going to end up in a whole different destination 10, 20, 30, 40 years into the future. So I like to say, let's empower ourselves and each other to make that small change in our training today so that we can have a better tomorrow. We can age better. We can be around for our children, our grandchildren, and, we can keep everything running as best as it can be.
Thank you for that. And Danielle, what are your parting words for our audience?
Oh, I guess my parting words would be very similar, echo, like definitely stay empowered for your own health. I love the saying, I heard it recently, that you are the expert of your own body. So you have to always be aware. Don't try to deny things, deal with it, you know, a step forward, always be proactive about your health and try to live a life that honors your body and your future.
That's wonderful. And just to add to what you said, from what you said earlier, find support when you need it to make sure that
Hmm.
you can be right. Like you can take those
Yeah.
proactive steps. Um, I see that there are more questions in the Q&A. I promise we will get you answers to those questions. So don't fret about that. But I just wanted to take this moment to thank both Dr. Kohli for your expertise. And just I feel like, you communicate things so clearly and directly, and I really appreciate that.
Mhm.
And to Danielle, thank you so much for sharing your story,
Of
and for
course.
being such an inspiration, I think, for so many folks that are struggling with their own health issues. And lastly, I want to thank our audience for being so
Yeah.
engaged and active with some really great questions today. As we continue this conversation throughout the year, Women Heart is really committed to releasing resources, hosting discussions, and providing support, as Danielle was talking about, to make sure that we together are exploring the interconnectedness between heart disease, diabetes, and kidney disease and overall metabolic health. Managing these conditions, I'm sure, can feel overwhelming, but we want to make sure you know that you are not doing this alone. Be sure to join us for our future health talks and watch your social media to find out when those will be. We are also releasing new resources on a regular basis on prevention, treatment options, and strategies for managing your chronic conditions. Please stay connected with us, visit our website, sign up for our emails, but mostly connect with each other. And I'm going to go back to Dr. Kohli's, be the captain of your own ship. I love that so much. Thank you, everyone. Thanks for staying on, and have a good rest of your day.